Hey, hi everybody. Welcome. Thanks for tuning in. My name is Dr. David Golombos. I'm one of the urologic oncologists here at Stony Brook University Hospital, and I'm here with Dr. Franceschi. If you'd like to introduce yourself.
Yeah, so I'm nuclear medicine physician here in Stony Brook and using imaging agents to detect diagnosed cancers and evaluate management of the cancers following the therapy.
Great. So, this is going to be comprehensive and interactive talk about, prostate cancer in general. We're also going to focus a little bit specifically on some of the newer and very exciting tests that have come out to help both kind of diagnose, prognosticate, and treat prostate cancer, specifically called the PSMA scan, which is one of the new technologies that at this point is really unique to Stony Brook here on Long Island, and is, very exciting in the world of prostate cancer. But we'll also cover, in general, just, what is a prostate, what is prostate cancer, kind of screening, diagnosis, treatment options, things along those lines. And this is meant to be a very, interactive discussion. So we welcome and encourage any and all comments as we're going about it. So we'll just kind of start with some generalities. I guess first, what is a prostate? So a prostate is an organ that's, unique to men. It's roughly about a walnut-sized gland that's located between the bladder and the penis and sits in front of the rectum. The urethra, which is the tube that you ultimately urinate out of, runs through the center of the prostate. The main thing that a prostate does is it actually has a role in fertility. So it basically, upon ejaculation, it secretes a fluid that nourishes and protects the sperm that basically help promote fertilization. However, a prostate can cause a lot of issues with men as far as urination and things along those lines. And unfortunately, it is an organ that's very prone to forming cancer. So prostate cancer in general is one of the most common malignancies in men worldwide. And certainly same goes for here in the United States. It's the second leading cause of death in the United States behind lung. There's roughly around 200,000 cases that are diagnosed every year, with roughly about 33,000 deaths. The average man at the age of diagnosis is 66 years old. Generally speaking, in the U.S., there's about a 1 in 8 to 1 in 9 lifetime risk of being diagnosed with prostate cancer, which, kind of lends to understanding how common it is. About 1 in 40 men will die of prostate cancer in the United States, but it's also estimated that currently there's anywhere between 3 and 3.5 million men who are living with prostate cancer in the United States. There are some risk factors that we know as far as prostate cancer goes. The biggest risk factor is honestly age. Prostate cancer is largely a diagnosis of aging. And as men get older, the risk of developing prostate cancer certainly increases. There are other kind of known risk factors as well. One being family history. Men who have a first-degree relative or strong family history of prostate cancer, especially that's diagnosed at an early age, are more prone to developing prostate cancer. So there are some screening guidelines that take that into account. It is also, proven that African-American men are not only at higher risk of developing prostate cancer than their Caucasian counterparts, but they also are at risk for developing higher risk disease. So again, they are kind of a subgroup of higher risk that we take into account, as far as our screening guidelines go. So, kind of pivoting then to screening, what screening for prostate cancer really consists of is two things. One is a PSA, which is a blood test, and the other is what's called a DRE, or digital rectal exam. The goal of screening in general is to detect prostate cancer early. And that way, prostate cancer that is detected early has a very high chance of cure. So what a PSA is? So a PSA is a protein that's circulated within the blood. PSA stands for prostate-specific antigen. It's not a protein that's exclusively to prostate cancer, but it is exclusive to the prostate. So the advantages of PSA, it's a very sensitive test, meaning that there are a lot of things going on within the prostate that can cause that number to be elevated. But it is not very specific, meaning that an elevated PSA alone is not diagnostic of prostate cancer, but it does alert us to somebody who might be at risk and who should undergo further testing. Digital rectal exam is a finger exam, basically where we're palpating the outside of the prostate. And what we're really doing is trying to feel for any asymmetry, any firmness, and most specifically any nodules, because sometimes prostate cancer can occur, and you can you can palpate it, and even when your PSA is not very elevated. So those are screening, which is again blood tests and a rectal exam. There are some variation in terms of screening recommendations. Generally speaking, probably the most effective time of screening is men who are average risk in between the ages of 50 and 75. In men who are at increased risk, either because of the strong family history, men who are African American, sometimes we start recommending as early as the age of 40 in terms of screening with PSAs and digital rectal exams. However, again, both of these tests are just for screening, and the only way that prostate cancer can actually be detected is with a biopsy. So basically these things, if you have an elevated PSA and abnormal digital rectal exam, that raises a level of concern, which might ultimately lead to a prostate biopsy. But again, that's the only way that prostate cancer can be detected. And then once we're diagnosed with a prostate cancer, then we start talking about options. Now, for most men, there are a very wide range of options as far as treatment goes, depending on what we'd consider the stage and the grade of the cancer. For cancers that are thought to be very early stage, very low risk, very clinically localized, active surveillance is something that's an option. What active surveillance is and the concept behind it is that there are certainly some prostate cancers that, even if detected, have very low likelihood of taking years off of your life. Some of these prostate cancers can sit what we call indolent for many, many years. And it's very safe strategy to watch them and then only intervene if they change, meaning that if on a repeat biopsy, if now they're at a higher stage, or if other things are concerning, such as your PSA is going up significantly, or if you have an imaging test, such as an MRI, that shows a change in the disease, then we would step in and treat the cancer. Now, there are some cancers that are more than low risk, and those are ones that we recommend treatment for. For clinically localized cancer, which means disease that's exclusive to the prostate and has not, escaped from the prostate, then the two main options for treatment revolve around either what's called a radical prostatectomy or some form of radiation therapy. Radical prostatectomies are also often done at our institution and nationwide as a robotic approach. So what's called the robotic-assisted radical prostatectomy, which is basically in a very advanced form of laparoscopic surgery with curative intent, where we remove the prostate, we remove the seminal vesicles, which are little organs that contribute to your ejaculate. We remove some of the lymph nodes to make sure microscopically we don't see any cancer within them, and then we sew the bladder back to the urethra. Very other effective treatment option for most cancers is some form of radiation therapy. There are a lot of ways that radiation can be delivered to the prostate, but in general concept is you're delivering radiation to the prostate and killing the disease within it while leaving the prostate in place. Sometimes that's combined with hormonal therapy, which is what we call a systemic therapy, meaning some means of treating the entire body. There's a lot of analogs, or people can, think along the lines of chemotherapy. Chemotherapy is not often used in prostate cancer, except in very advanced stages. But hormonal therapy is, again, a means of something that's circulating throughout your entire body, and it is one of the mainstays for advanced disease. So, one of the, after treatment for prostate cancer, a lot of cancers are treated successfully, with their initial treatment. But unfortunately, sometimes prostate cancer can recur. And usually the first sign that there has been a recurrence is with a PSA, that blood test. So after treatment for prostate cancer, if your treatment is surgery, your PSA should essentially go down to what we would consider undetectable, meaning that there is really nothing within the body that is still producing that protein. And if that is the case, then there's really not a role to do any imaging or anything along those lines as far as trying to, as far as surveillance goes. After radiation, your PSA usually is not going to go down to undetectable, but it should go down to very low levels, and it should stay that way. Now, if unfortunately that PSA starts rising based on the blood test, that does raise the concern for recurrence. Generally speaking, that recurrence could really be what we'd consider a local, regional, or distant recurrence. And that's, really where a lot of these advanced testing, which we're going to get into shortly, come into play. So if we have a blood test that's showing now that there is PSA still within the body or recurring within the body, there's really, trying to figure out where it is of paramount importance. If you've had surgery or radiation, a local treatment would be a recurrence of prostate cancer cells either within the prostate itself or the area where the prostate was, which is kind of called the prostate bed. Regional recurrence would be something such as the pelvic lymph nodes. That is one of the first spots where if prostate cancer was to make its way out of the gland, that's where they would arise. And that's kind of the, lymph nodes that are deep down in the pelvis, kind of alongside of the bladder. A distant recurrence would be somewhere else, bones, lung, somewhere that's kind of that's further in the body from where the cancer originated. Now, one of the difficulties until recently is that conventional imaging in this scenario has really been somewhat limited in terms of trying to help us determine, where this disease is, especially if we're talking about, very low levels of PSA. So if there's your blood test is now showing that there's something within the body that's producing PSA, what we would consider conventional imaging, which is usually a combination of a CAT scan and a bone scan, is very limited in terms of its ability to detect that. And that's really where a lot of this excitement for some of these newer molecular scans is coming from, and is really, very exciting within the field of prostate cancer. And so I'm going to pass it off to Dr. Franceschi to talk a little bit more detail about, what these scans are and why they're so valuable to treatment and diagnosis and care.
So, as Dr. Golombos said, there is a lot of excitement recently with first approval of new imaging tracer to detect prostate cancer. And one of these is PSMA, which means or stands for prostate-specific membrane antigen. So what is the PSMA? PSMA is our biomarker target on prostate cancer cell. It's surface antigen, actually it's enzyme, which is expressed pretty much in majority of prostate cancer cells, in about 80 to 90% of prostate cancer cells. So what is even more important is that this PSMA expression increases in cancers which are more aggressive and more widespread, and therefore that is perfect target for the imaging agents. So it is not expressed in normal tissues, but pretty much just on the prostate cancer cells. So it's almost ideal biomarker for prostate cancer. And that comes in particular important after initial treatment, when PSA is undetectable or very low and start to rise, to find out where is actually location of this prostate cancer recurrence. So when PSA is rising, we call that biochemical recurrence. And PSA is very sensitive, as it was said, but we don't know where it's coming from. Where is this recurrence located in the body? So that's why PSMA imaging agents are very important. They are very sensitive to detect recurrent disease and to detect extent of this recurrence. And why is that important? Because then you can actually tailor your therapeutic approach. How are you going to treat? You have to know what you are treating. So if you don't know where is that recurrence, you will be not able to treat successfully. And that's why a PSMA imaging is very important. Another important feature of these new PSMA imaging agents is that when you attach different kind of radiation, you cannot just, or you don't have just to image patient, but you can even to treat patients. And there are trials actually using PSMA. Recently one is completed, and for these PSMA compounds that can treat a recurrent prostate cancer. So that's why this excitement is coming. And first PSMA imaging agent that was approved was Pylarify the end of May this year. Actually, there was one which was approved in December last year, but just for 2 institutions in the USA. So the first imaging agent, PSMA agent, that was approved for widespread use throughout the country is Pylarify in May of 2021. And the specific indication that FDA granted approval are two major indications are. And these are for patients with suspected metastasis who are candidates for initial treatment. So in particular, patients with high risk, even intermediate risk, to detect possible early metastatic disease that you can, again, more successfully to treat, or even avoid a radical treatment if there is already spread of the cancer in the body. So that's one indication. And the other major indication is actually in patients with biochemical recurrence. So that means suspected recurrence based on elevated PSA levels. We started using these PSMA agents even before approval within a trial in our institution in Stony Brook within the last 2 years, and we were imaged about 25 patients until now, and now we are beginning to image patients also with after approval within clinical indications, as I said, for patients with suspected metastasis at initial diagnosis and with suspected recurrence based on elevated PSA levels. And I think that's pretty much it about these PSMA imaging agents. Brand name it's called Pylarify, and as I said, we started using even for clinical indications here in Stony Brook.
Yeah, thanks, Dr. Franceschi. So I'm just going to elaborate a little bit on that question about who qualifies. Thank you, Nick, for posing the question. So like Dr. Franceschi said, there's really these 2 scenarios. The first is in the untreated, and then the second is in the patient who's been treated, who you're concerned about a recurrence. Now, in the untreated patient, so if we diagnose a man with prostate cancer, we're able to put you into these risk categories based on certain features. So there's really men with low risk, intermediate risk, and high risk prostate cancer. And that's based on largely a couple of things. One, how high is your PSA? PSAs that are elevated but relatively low are, kind of keep you into the lower or intermediate risk categories. PSAs that are very high, if we're talking 20 or above, that kind of by definition puts you into a higher risk category. Another thing is imaging tests such as, an MRI that we often use early on in the diagnosis. MRIs can tell us if there's cancer within the prostate, but they can also tell us where there's concern about a tumor that looks like it's bulging or invading outside of the capsule of the prostate, which puts you at a higher stage and a higher risk disease. And then most importantly is your biopsy results. So when you get a prostate biopsy, it doesn't just tell you, is there a cancer, yes or no? It'll tell you how many of the samples had cancer, what portion of those samples, but most importantly, it'll tell you what's called a Gleason score or a Gleason grade. And what that is that's the language that a pathologist communicates to us about how aggressive these cancer cells look under the microscope. And so historically, we would have Gleason scores that ranged from 6 to 10. We've kind of changed the way we describe them now into these grade groups from 1 to 5, lower numbers, less aggressive, higher numbers, more aggressive. So in men with, low risk or kind of favorable intermediate risk disease based on these parameters, there's a very, very low chance, based on our understanding of the disease, that you're going to have metastasis, meaning spread outside of the prostate. However, as we start talking about these higher risk disease on diagnosis, so men with Gleason scores of 8, 9, or 10, which are now grade groups, 4 or 5, men with MRI that shows concern about a tumor outside of the capsule of the prostate, or men with very high PSAs, then their chances of having disease outside of the prostate starts to increase. And traditional imaging, CAT scan, bone scan, if there's widespread metastasis, it certainly can pick that up. However, if there's microscopic disease outside of the prostate that hasn't caused those lymph nodes to look enlarged or things along those lines, then these type of molecular tests, such as a PSMA scan, can really, look at the lymph nodes and things like that as sensitive and specifically as possible, to see if they're actually, if we do suspect there's disease outside of the prostate. Because as Dr. Franceschi said, sometimes that does dictate how we think about the disease. For example, if somebody has very high risk prostate cancer, we do a test and unfortunately it shows that there is, enlarged lymph nodes or, disease in their, bone or something along those lines. Simply by removing the prostate surgically, we're not going to be really addressing all of their disease. And so that then changes our approach to something that's also going to, treat the, disease that's outside of the prostate, whether that be, often a hormonal therapy or something along those lines. And so that's the one setting is the high risk untreated. And then as he, talked about very nicely, the other is the recurrent patients. So somebody's who had treatment who, now there is usually a blood test, the PSA, that is starting to increase, raising our concern that there is something going on as far as a recurrence goes. Then that scan could help us localize it, whether it's within where the prostate itself or where the prostate was, the lymph nodes or somewhere else. And that again does dictate then how we would potentially approach that recurrence. Sometimes we watch them. Sometimes we treat them with radiation. Sometimes we treat them with hormones or other agents. And so, those are kind of the two main indications. So it's certainly not a test for everybody. And it's not a test that, everybody with prostate cancer who's been treated for prostate cancer, should get. But it is something that can certainly be very helpful in these circumstances. So I think there's a question about, kind of the logistics about where they can get these scans done. Dr. Franceschi, maybe you'd like to elaborate on some of the logistics about where they can have these done if they're indicated.
Yeah, right now we are doing that in our outpatient facilities at Stony Brook Road and in the Riverhead. Stony Brook Advanced Imaging facilities at Stony Brook Road and in the Riverhead.
Yeah, and so a scan, this is generally, just so you're understanding, it is similar in the line of, a CAT scan or a bone scan or, other tests that, probably a lot of us are somewhat familiar with. As of right now, it is it's a diagnostic scan. It's just a very specific type of scan that's very specific to prostate cancer. But another exciting thing, and Dr. Franceschi mentioned this, is that it does also open up potential for even treatment based on these scans. So, this is a concept that's used in some other diseases, specifically something like thyroid cancer. But, we have there are trials undergoing now where looking at if you're, to keep it as layman's terms as possible, kind of coupling a radiation or radioactive agent to this tracer. If that tracer then kind of seeks out these prostate cancer cells and has some form of, radiation activity attached to it, ultimately we could be treating patients, with this type of imaging and, coupled with radiation technology. So that's not anything that's, being done outside of clinical trials right now, but there are a lot of exciting clinical trials that are starting to report, looking at this, which also opens up a whole nother world of possibilities as far as, treatment of advanced disease goes. We welcome more questions or comments. So if anyone has anything they'd like to, hear more about, whether it be about the scan in general or about, prostate cancer or, questions specific to Stony Brook and what we offer, love to hear them. So I did see a question that seemed to pop up earlier just about, kind of where else these tests are being used. So, these are tests in some respect that have been used internationally for some time. Specifically, I think Australia and Europe have been some of the, bigger, early adopters of this. So they've looked at them in some respect for a while. And only more recently have they kind of gained more approval and, started to become more widespread use here. So I don't know if Dr. Franceschi, maybe you want to just elaborate a little bit more on that about, where they've been using them, and then kind of the, a little bit more on the trials that we've done here, and then what's transitioned now to being able to use them, kind of outside of a trial.
Yeah. So as Dr. Golombos said, they've been used in Europe and Australia for about the last 10 years. And there is a lot of experience. So this is nothing new, actually. The only new thing is that is now available in the United States, and that FDA granted approval finally this year for this kind of imaging. Again, it's much more sensitive. Again, I have to emphasize, much more sensitive than conventional imaging like bone scan and CAT scan. And that's why we were waiting anxiously for a long time to have availability of these more advanced imaging techniques, because really they are kind of game changer in the management and treatment of prostate cancer. So in terms of our experience, as I said, we were using for imaging for the last 2 years, and we are just preparing to be ready if approval comes for the therapy agents as well. They are also used for last at least 5-6 years in the Australia and Europe. So again, exciting times for us with these new imaging agents, and it's great thing for patients that can be treated more successfully and earlier when we know where disease has spread.
Yeah, and look, I'd say, this is just one of the advantages of kind of, being as part of a, an academic center and, part of a cancer center and things along those lines, is that, as Dr. Franceschi said, the way a lot of these things work is that even though they've been used elsewhere and shown to be safe and useful, say in Australia or Europe, there's a completely different process about how these things get approved, within the United States by the FDA, and that process can take a while. And so one thing that's nice about, here at Stony Brook is we do, we're part of a lot of these clinical trials, where we're able to get patients access to these type of scans, even before they're officially approved by, by the FDA. So, we've been using these scans clinically, as part of a trial for a couple of years now. They certainly have, we've been very excited about being able to use them more widespread because, we have had really good, results with these in terms of, changing real-time decisions about how we're going to address the cancer. And so, not only with these types of molecular imaging scans, but we do have, other types of, clinical trials, both within the world of prostate cancer, within other urologic malignancies, and, across multiple different malignancies in general that our cancer physicians and our cancer comprehensive teams are, very excited to offer. So, that is just one thing in general that, as a concept, being treated at somewhere, that can offer clinical trials really does, allow, when appropriate, early access to some of these things that, we've really wanted to use for a while, but are just a little bit handicapped until they're, officially approved and ready for more widespread clinical use. So right now, I believe in this, we are still the only kind of center in Long Island that, that is offering these scans, because even once they are approved, there is a lot of other things that go into getting them up and running. And one thing that did allow us to become very, early adapters and get this early up and running very quickly after the approval is, as Dr. Franceschi said, is that we've had familiarity with these scans for the last couple of years, in the trial setting. So once, we kind of, officially got approval, we were kind of, very able to, hit the ground running in terms of getting this up and going for clinical use, which has been very exciting. Any other questions? All right. So, I hope we're able to provide some information to everybody. We have been a little bit more limited in terms of prostate cancer screenings over the last, year or so because of COVID, but, hopefully we'll be able to get back out into the community and, kind of offer more of the, early detection kind of screening, things along those lines. As far as PSMA goes, again, it's not for everybody, but we are very, very excited here to be able to, offer this, first in Long Island to, our prostate cancer patients here, because we really are firm believers that, this is going to make a big difference in terms of our ability to identify and treat the disease. So I, direct you to the link here at the bottom of the page for more information, about our, cancer team, specifically about PSMA scans, etc. So I encourage you to log in and check that out. And I'd like to thank, Dr. Franceschi for his efforts, getting this up and going, both in the, kind of the, like I said, the trial setting and more recently in the clinical setting. I'd like to thank him for, kind of being here today to help with his, explanations and, kind of letting people know, these scans are available and how they're best used. And would like to thank, kind of the production team for letting us be on here and chatting with you guys here today.